Good afternoon, everyone. Let me present my progress in the last year in my PhD topic, which is novel approaches in treating pancreatic ductal adenocarcinoma. My name is Melinda Piri. I'm a clinical oncology resident in Szombathely and a PhD student here. Our shared vision with my team is that pancreatic ductal adenocarcinoma could one day become a curable, but if not, at least a chronic disease. And our mission to achieve this is to find treatment options to enhance the survival rates of these patients. Last autumn, we launched 2 projects. Both of them are focusing on already existing but not that widely used treatment options for these patients. The first one focuses on the oligometastatic subpopulation of PDAC patients, and the second one tries to find the role and place of targeted therapies in advanced patients. Now let's see some numbers why we need a new breakthrough in this field. Pancreatic cancer is the 3rd leading cause of cancer-related deaths in the United States. And all of the pancreatic cancers, 80% are pancreatic ductal adenocarcinoma. And the incidence of this is rising worldwide. And the most important information on this slide that this disease often remains asymptomatic for a very long period of time, and therefore more than 80% of the patients present with an advanced stage disease, which means they are no longer eligible for a curative intent treatment. So in my first project, evaluating the efficacy of multimodal treatments in oligometastatic pancreatic ductal adenocarcinoma, we are focusing on a subpopulation. But who are oligometastatic patients? We are talking about oligometastatic disease if there is not more than 5 metastases present in one affected organ. They can occur either synchronously at the time of the diagnosis or metachronously after a definitive treatment of the primary tumor. And why do we think these patients might be special for us? The idea of oligometastatic disease relies on the branch devolution of tumors, which states that in a tumor mass there are different subpopulations of cells evolving next to each other, and for a quick metastatic propagation we need one very strong clonal driver, and because of these different parallelly evolving subpopulations, it takes time to select out that one driver mutation, and in this time frame the tumor mass have a reduced metastatic efficiency, which means it behaves more like a localized tumor even though it's metastatic. And in this time frame, we have a potential chance to cure this patient with a more aggressive approach with metastasis-directed multimodal treatments. So our aim was to investigate the impact of metastasis-directed multimodal treatments on survival of the oligometastatic patients. We raised a clinical question: do these metastasis-directed multimodal treatments provide a better prognosis compared to the standard of care, which is chemotherapy, in oligometastatic patients? We used the PICO framework, and our population were oligometastatic patients who undergo systemic chemotherapy. And we had 4 groups of intervention: surgical removal, radiation therapy, interventional radiology, and any combination of these 3. Our comparator was no additional treatment, and our primary outcomes were overall survival and progression-free survival. And we hypothesized that multimodal treatments provide a better overall and progression-free survival for these patients compared to the systemic chemotherapy. Our clinical and research implications would be to improve the survival rates. We used the following search key to conduct our systemic searches in last November. The first 2 domains refers to our population, and the third one refers to chemotherapy, as everyone had to receive chemotherapy to be included. And we found around 10,000 articles, and with careful selection we reduced the numbers with 34, and with citation chaser process we added an additional 24 articles, and in the end we ended up with 58 articles. So as of the progress of this project, we are done with the data extraction. However, the figures and tables are still in the making. We did the scope bias assessment, working on the grade, and the method section is drafted already. We have only, unfortunately, ongoing analysis, but we are able to do subgroups based on the localization, the timing of the metastasis, and the use modality of treatment. Now let's jump to my second project, investigating the effectiveness of targeted therapies in advanced pancreatic ductal adenocarcinoma. I already talked about why PDAC is a major health burden, and we had a little session about the local adaptive treatment options. Now let's jump to the systematic ones. We know that systematic chemotherapy prolongs the survival of these patients. However, immunotherapy seems quite ineffective because of the immunosuppressive nature of the tumor microenvironment. Therefore, now our eyes are on targeted therapies, where they be the next breakthrough. With the genomics, now we know that pancreatic cancer has a low mutational burden, the lowest among gastrointestinal cancers, and the molecular profile is driven by KRAS mutations, which is not a good news for us. As you can see on the table, we have only 2 drugs available right now, which target one specific KRAS mutation, which has only 1 to 2% of the population. Therefore, the benefits of targeted therapies in the overall population is not very well established, and we would like to investigate if this patient really have a survival benefit with targeted therapies. So we raise a clinical question: do different targeted therapies improve survival compared to the standard of care in advanced PDAC patients? We use the PICO framework again. The population was advanced PDAC patients. The intervention was targeted therapy, or comparator is no targeted therapy, and the outcome is overall survival and progression-free survival again. And we hypothesized that targeted therapies improve survival in advanced PDAC, and the clinical and research implications were, again, to improve the survival rates. So we have this preliminary search key, with which we have around 10,000 hits again. We did find previous meta-analysis from the last decade, but since then we have numerous new randomized control trials. And we found one Prospero registration for network meta for patients with BRCA mutations. So to sum up, we launched 2 projects last autumn, and we plan to submit the first one about the oligometastatic patients in November, and the second about the targeted therapies in next year, September. So let me finish my presentation with the words of Nelson Mandela: "It always seems impossible until it's done." Thank you for your attention.
Thank you very much. Who has any questions, comments?
So you don't have any analysis done yet, but you've done a great work with the 58 studies from which you have extracted primary data. Reading through these studies, what was your impression? Is it meaningful to add anything to the treatment of these patients?
Well, that's a complex question to answer with yes and no. So the results...
Then I'll limit this. When is it beneficial to add?
Yeah. So the results were promising, but most of with one exception, all of my articles were retrospective observational studies. Therefore, the patients are very well selected in these articles, and selection bias is there. But in those articles, the results were promising. So, with one exception, in all articles, as I remember, the survival was better for the metastasis-directed treatment group than the only systematic chemotherapy group. And we have one randomized control trial about the SBRT, which proved a significant survival benefit for the patients, and it's already in the guideline.
SBRT of the metastatic?
Metastasis,
metastasis,
yes.
Not the primary tumor.
So either both, or in the case of metachronous metastasis, the removal of a primary tumor happened before, and the SBRT of the metastasis only.
Okay, thank you.
Regarding the second project, target therapy, I'm wondering, because I thought it is clear, targeted yes or no, what the guidelines saying, NCCN guideline, for example.
So some of the targeted treatments are recommended in the first line treatment as an option which we can choose, but obviously you have to do the genetic testing first, and it takes time. So I think in the case of every patient, we start systemic chemotherapy first, and we can switch as a second line treatment maybe, or add to gemcitabine, for example. So, yeah.
Okay, thank you.
How would you account for publication bias in your first topic? Do you feel is there any? Or what those studies, what you found shows, if every or most of the studies shows some minimal, even minimal benefit,
I think
also
probably
need to suspect.
I think probably there will be publication bias as well. Yes. The problem is that it's not a very common state for these patients. So the average number of the sample size was around 30 patients in most of the studies over 5 or 10 or 15 years. So yes, I believe we have to account for the publication bias. I don't know yet how we will do it exactly.